What if the surgery your doctor just scheduled for you? The one you already signed the consent form for. The one your family is telling you to just do and get it over with. What if that surgery was not going to fix you? What if it was going to leave you in more pain than you are in right now? What if I told you there are 5 surgeries being performed in hospitals every single day on millions of people just like you, that leading medical researchers now call unnecessary, dangerous, and in some cases, completely ineffective? What if the most powerful thing you could do for your health today was simply to stand up, pick up your bag, and walk out of that doctor's office? Stay with me. Because what I am about to tell you could be the most important thing you hear before you ever let anyone put you to sleep on an operating table. Informed consent is not enough. Doctors are legally required to explain risks, but they rarely tell you the full picture of long-term complications, failed outcomes, or alternatives that could work better without going under the knife. Surgery is a business. Many elective and semi-elective surgeries are heavily influenced by financial incentives. Hospitals and surgeons profit from procedures, which can cloud medical judgment when a conservative treatment would suffice. Second opinions save lives. Studies show that nearly 20.30% of surgical recommendations change when a patient seeks a second opinion. Walking out and asking another doctor is not rude, it is survival intelligence. Complications are underreported. Post-surgical complications, chronic pain syndromes, nerve damage, and revision surgeries are far more common than the glossy brochures in waiting rooms suggest. The 5 high-risk surgeries, spinal fusion, knee arthroscopy for arthritis, laparoscopic hernia repair, certain types, routine hysterectomy, and unnecessary cardiac stenting are among the most overprescribed surgeries with questionable outcomes for many patients. Your body, your decision. Medical paternalism is real. Many patients are pressured into surgery through fear tactics. Understanding your rights and the alternatives is the most powerful tool you have. What if everything you believed about surgery, that it is safe, that it is necessary, that your doctor always knows best, was only half the truth? Every year, millions of people go under the knife believing they have no choice. They are told the surgery is routine. They are told the risks are minimal. They are told this is the only way. And then, far too many of them wake up on that operating table, or don't wake up at all the way they used to be, and discover something their surgeon never told them, that there was another way. That the evidence was never as strong as the confidence in that white coat suggested, that they were, in the most terrifying medical sense of the word, operated on unnecessarily. I am not here to tell you that surgery is always wrong. Surgery saves lives. Emergency surgery, cancer surgery, trauma surgery, these are miracles of modern medicine. But there is a category of surgery, elective, recommended, scheduled, pushed, that deserves your most serious skepticism. And today, I want to walk you through 5 of them. 5 surgeries that, based on growing mountains of peer-reviewed evidence, I would personally never agree to. 5 surgeries where, if your doctor hands you that referral form, the bravest and smartest thing you can do is pause, breathe, and say, "Doctor, I need to think about this." Let us begin with the first one. Spinal fusion surgery. Every single year, hundreds of thousands of people are told their back pain is so severe, so structural, so mechanical, that the only solution is to literally bolt 2 or more vertebrae together with metal rods and screws. It sounds dramatic because it is dramatic. It is irreversible. And here is the part that will stop you cold. A landmark study published in the journal Spine found that patients who had spinal fusion for chronic lower back pain had outcomes that were no better, and in many cases significantly worse, than patients who received physical therapy, pain management, and cognitive behavioral therapy. The surgery fused their bones. It also fused them to a life of limited mobility, chronic stiffness, adjacent segment disease, where the vertebrae above and below the fusion begin to deteriorate, and in many cases, a second surgery to fix the problems created by the first. If your doctor recommends spinal fusion for non-emergency back pain, you owe it to yourself to exhaust every conservative option first. Walk out if they pressure you. Get a second opinion. Your spine is not a construction project. The second surgery on this list will surprise you because it sounds so logical. Knee arthroscopy for osteoarthritis. You have knee pain. The doctor sends you for an MRI. The MRI shows wear and torn meniscus tissue. The doctor says, "We can go in there arthroscopically, clean it all out, and you will feel much better." It sounds reasonable. It sounds minimally invasive. It is one of the most commonly performed orthopedic procedures in the world. and a groundbreaking randomized controlled trial, one of the gold standards of medical evidence, published in the New England Journal of Medicine, compared actual arthroscopic surgery to a sham surgery, where patients were cut open, put to sleep, and then sewn back up without any procedure being done at all. Both groups reported similar levels of pain relief and improved function. The surgery itself was no more effective than a placebo. The patients who got the real surgery still felt better, but so did the patients who got nothing. Their brains did the healing. Their brains believed the surgery worked. And the patients who had the real surgery still faced the risks of anesthesia, infection, blood clots, and the emotional and financial cost of recovery. If your doctor is recommending knee arthroscopy for arthritis pain, ask them about the evidence. Ask them about the sham surgery studies. Watch their face. Then make your decision. The third surgery is one that affects hundreds of thousands of women every single year, and it carries with it a weight of pain, identity, and institutional failure that is almost too large to speak about in a single speech. Hysterectomy, the surgical removal of the uterus, is the second most common surgery performed on women in many countries, and a significant portion of them are performed for conditions that can be managed without removing an organ permanently. Fibroids, heavy bleeding, endometriosis, pelvic pain, all of these have alternative treatments. Uterine fibroid embolization, hormonal therapies, minimally invasive procedures, lifestyle interventions. Yet women are routinely told the quickest solution is just to take it out. There is nothing quick about losing an organ. There is nothing simple about surgical menopause, about the hormonal cascade that follows, about the increased risks of cardiovascular disease and bone density loss that come with early hysterectomy. If you are a woman and your doctor is recommending hysterectomy for a non-cancerous condition, without first discussing every single alternative in detail, you are not being given the full picture. You deserve the full picture. Walk out, find a doctor who will give it to you. The fourth surgery on this list involves your heart, and that alone should make you pay very close attention. Coronary stenting, the insertion of a small mesh tube into a narrowed artery to open it up, is a life-saving procedure in the context of a heart attack. In that emergency setting, it is nothing short of miraculous. But stenting for stable angina, chest pain that is managed with medication and does not represent an immediate emergency, is a different story entirely. The Orbita trial, one of the most controversial and important cardiology studies in recent memory, again used a sham-controlled design. Patients with stable angina were either given a real stent or a fake procedure. And the results? The stent group showed no significant improvement in exercise tolerance or symptom relief compared to the sham group. For stable angina, medication management, beta blockers, nitrates, lifestyle changes perform just as well as an invasive cardiac procedure. Yet stenting for stable angina remains one of the most lucrative and widely performed cardiology procedures in the world. The financial incentives in cardiology are enormous, and your life may literally depend on knowing the difference between a necessary stent and a profitable one. The fifth and final surgery I want to discuss today is one that touches on some of the most vulnerable moments a person can experience. Back surgery for disc herniation. Specifically, discectomy and laminectomy performed on patients without severe neurological symptoms. Disc herniations sound terrifying on an MRI report. Bulging discs, herniated discs, impingement. The language of spinal imaging is designed, intentionally or not, to make you feel broken. But here is what the research consistently shows. The vast majority of disc herniations, even significant ones, resolve on their own within 6 to 12 weeks. The body is extraordinary at healing these injuries when given time, movement, and proper rehabilitation. Multiple studies have shown that for patients without progressive neurological weakness, meaning no loss of bladder or bowel control, no rapidly worsening leg weakness, the long-term outcomes of surgery versus conservative management are nearly identical at the 1-year and 2-year marks. The people who had surgery felt better faster in the short term. The people who waited and rehabilitated felt just as good 12 months later, without the surgical risks, without the recovery time, without the scar tissue, without the potential complications. If you are being rushed into back surgery for a disc herniation and you do not have those emergency red flag symptoms, slow down. The urgency your surgeon feels may not be the urgency your body actually requires. Now, I want to be absolutely clear about something, because this is important. None of what I have told you today is an argument against medicine. It is not an argument against doctors, who are, the overwhelming majority of them, people of enormous skill, dedication, and genuine care for their patients. What I am arguing against is the culture of surgical default. The culture that says, when in doubt, cut it out. The culture that has failed to keep pace with the evidence. The culture that does not always leave room for the patient, for you, to ask questions, to pause, to seek a second opinion, to say, I am not ready, I need more information. You are allowed to not be ready. You are allowed to ask questions that make your doctor uncomfortable. You are allowed to walk out of an office that is pressuring you in a state of fear toward an irreversible decision about your own body. That is not defiance. That is self-advocacy. And in the context of these 5 surgeries, it may be the best medical decision you